Welcome to the Ortho on the Go podcast. My name is Chuck Dowell, host of the podcast. This is an educational orthopedic podcast focused on discussing both clinical and functional orthopedics. We will discuss a variety of topics within the field of orthopedics, including reviewing interesting cases, hearing from different professionals throughout the orthopedic profession, and discussing common musculoskeletal injuries and complaints. This podcast is meant for anyone that wants a better understanding of orthopedics, including all levels of practitioners, coaches, parents, and athletes themselves. Welcome back to the podcast, everyone, and thank you for joining me. I had an interesting case this week, which I think is a common case that we see quite often in the orthopedic clinic, urgent care, primary care office, and just in general that I thought would be worth discussing. And I know it's a common topic that we discuss a lot. I had a 65-year-old gentleman present to me with an acute onset of increased swelling within his left elbow. No trauma, no injury to the area. I just woke up and noticed increased swelling within the elbow. Was diagnosed with olecranon bursitis by his primary care provider. Was sent to orthopedic urgent care for evaluation to discuss treatment options, including possible cortisone injection within the area. We often get a lot of patients that are sent for these cortisone injections within this olecranon bursal area. And I thought it would be worth it to kind of discuss our algorithm for treating these patients and just kind of the general thought process for treating these patients. It is a bit of a controversial topic. You'll hear definitely different discussions regarding this. Recently at a meeting, there was a really good conversation regarding infectious bursitis, both pre-patellar and olecranon bursitis, which I think often could be treated similarly. A couple things which I think are important to establish are, one, the timeline. Is it an acute or a subacute or a chronic case? Did it just start, again, like this gentleman? Is it something that's been there for a while? They've tried to treat it conservatively after kind of looking it up online? Or is it chronic? It's been treated multiple times in the past and it's not necessarily getting better. Again, was there a traumatic event? Some of these bursitises can come from striking the elbow on something, but most of them do come from microtrauma, just small, frequent injuries to the area. And with the skin over the olecranon bursa and pre-patellar bursal area being kind of dry and often having kind of cracks in the skin, oftentimes there can develop a bursitis within this area. Important to discuss if the patients are immune compromised or not. And then, is this your typical exposure? Any patient with something like this, we're definitely going to get x-rays just to see if there's any underlying osteophytes, bony abnormalities, calcifications as well. I will tell you that I did have a case recently of a gentleman who presented with olecranon bursa inflammation or fluid collection. His was traumatic, but traumatic as in he was pushing himself out of a chair and then noticed the pain. Originally was diagnosed with olecranon bursitis, but after testing him for strength testing and having him push down against my arm and or do an overhead kind of tricep extension activity against gravity, he had significant pain. Subsequently, there was a concern about a possible underlying triceps tear. MRI was performed, and the MRI did show a high-grade partial, if not near complete, triceps tear within the area. We were able to treat this conservatively, but sometimes these high-grade partial tears do have to be treated surgically. So again, evaluating the patient and any possible injury or trauma that could cause the onset of symptoms, I think, is very important with all of these cases. And then I think looking for common signs and symptoms that we see with a lot of these. So some of the common signs and symptoms that we see are tenderness. And I think it's important if we're trying to diagnose aseptic versus septic bursitis, noting that tenderness can be present in both of these, more common in septic than aseptic. Erythema and cellulitis can often be present, again, more common, by 80+% in septic versus aseptic. And then warmth is often again in septic bursitis. So if a patient comes in and they have fairly significant tenderness, they have erythema surrounding the area, and they have warmth, then likely this is an underlying septic bursitis instead of an aseptic bursitis. If they don't have any of these, they just have the fluid collection but full passive pain-free range of motion, no warmth, minimal tenderness, and no overlying cellulitis and or erythema, then likely, again, this is probably an aseptic bursitis. Often these can be treated non-surgically and non-invasively, especially with the aseptic bursitis. We typically try to treat those non-invasively if at all possible Typically, we do not aspirate these because oftentimes a fistula can form with aspiration of these bursal sacs, and that can cause a chronic drainage and unfortunately lead to possibly surgery regarding this. If we are going to aspirate them, we try to aspirate from the top down, so trying to go from superior to inferior and trying to create a large skin bridge. So kind of digging subcutaneously above where the bursal sac is at before entering the bursal sac. So therefore, if gravity and or against gravity will prevent the fistula from forming, and ideally the skin bridge will close and prevent a chronic drainage from the area. So if you are trying and or doing an aspiration of these, don't go directly over the area. Don't especially go inferiorly, because then gravity could cause a draining fistula from the area. Again, most of the times we can treat these non-surgically. The typical treatment for non-surgical pre-patellar olecranon bursitis would be compression to the area to allow the body to naturally resolve this. You can get those arm sleeves that a lot of the NBA players will wear, and or the leg sleeves that a lot of them will wear. They can wear this consistently. If it's somebody oftentimes with pre-patellar bursitis that is a carpenter or somebody that works on their knees, we'll have them get carpentry pads and or knee pads to wear to try to reduce the repetitive trauma to the area and ideally help to decrease the recurrent inflammation. Obviously, they can continue with ice and over-the-counter oral anti-inflammatories. Occasionally, if it's a refractory case, you can put them in a splint, a long arm splint for some time period, usually 5 to 7 days, to try to allow the soft tissue and inflammation to settle down and then progress them with activities. If there is a concern about septic bursitis, they have these overlying symptoms that we previously discussed, the tenderness, the erythema, the warmth, then a lot of the times these can be treated non-surgically as well. So oftentimes these are treated with antibiotics. Now, most of the time, the bacteria that are causing the septic bursitis are typically MRSA and MSSA. So, it's hard to distinguish the difference between the two. Usually MRSA is abrupt onset with abrupt onset of increased warmth and redness. But again, without an aspiration, it would be hard to distinguish between the two. Also, you could have a possible overlying strep infection as well. Strep pyogenes could also, or group B strep, could also be causing the superficial skin infection. So when thinking of antibiotic treatments, you definitely want to make sure that you're treating for strep, MSSA, or MRSA. How do we know which ones to treat? If we're concerned about an MRSA, we can do a doxycycline or clindamycin. One of the things at this conference, which I thought was quite interesting, was Bactrim, which we typically think of for treating MRSA or staph infections. We originally thought had fairly poor strep coverage. We now know that this has actually quite good strep coverage, and this infectious disease doctor was presenting the literature regarding this, showing how good the strep coverage was for Bactrim. So oftentimes he recommends a single treatment of Bactrim, and he gets good MRSA, MSSA, and strep coverage with this, and oftentimes can get resolution in the patient's symptoms unless it's an atypical bug that's causing it. When to aspirate and when not to aspirate is always a good question. I typically don't aspirate when there's overlying erythema, because if it's a non-infected aseptic bursitis and I take the infection from the skin and introduce it into the bursal sac, then I can create an infection. So oftentimes, if there is an overlying cellulitis and I worry about a septic bursitis, I'll try a duration, 7 days to 10 days of antibiotic therapy, and see if this can cause resolution of the symptoms. If it doesn't cause resolution of the symptoms, then I may perform an aspiration at that time. The aspiration will give me a better idea of any possible and or what specific bacteria could be causing the infection, and therefore I can optimize the antibiotics to specifically for this bacteria. But oftentimes with just a single cover antibiotic, it'll get better with the treatment. So I think it's worth it, as long as I don't have any significant side effects, to try this. And again, I've had quite good success with Bactrim since this recent conference. He, at the conference, quoted a lot of literature showing that quite a bit of these cases and or a majority of these cases do get better with conservative treatment and don't require surgical treatment. If they do require surgical treatment, then obviously I think referral to the orthopedic specialist is required at that time, and they can do a bursectomy. There's obviously different ways to do these bursectomies. Sometimes these bursectomies can be refractory, and they may require 1 or 2 surgeries afterwards. So we try to avoid surgical treatment at all costs due to the higher concerns for possible complications regarding this. So if you're seeing these patients in clinic and you're seeing these olecranon bursitis and or pre-patellar bursitis, again, if they are non-infectious, aseptic, don't have any overlying warmth, tenderness, or erythema, I think worthwhile to try to treat them conservatively with possible immobilization, oral anti-inflammatories, topical anti-inflammatories, and compression around the area. I would save the aspirations for these and or the injections for these for refractory cases because there is some literature that shows the injections can actually cause worsening problems. If it's a refractory case, then go ahead and refer to the orthopedic clinic, or if you feel comfortable, fine to do an aspiration and injection. But again, try to build a big skin bridge over the area and try not to aspirate from the inferior aspect as not to cause a draining fistula within the area. If it is a possible septic bursitis with an overlying cellulitis and or overlying erythema, then I think worth trying an antibiotic regime of your choice. Again, if you think it's MSSA or strep, you can try a Keflex type medication or a possible third generation cephalosporin. You can also possibly consider augmentin and or clindamycin if there's any concern for resistance. If it's MRSA, you can do the doxycycline plus the amoxicillin, the clindamycin again, or you can try Bactrim for a single coverage, which again will have good coverage with all of these, including strep as well. If it's refractory to this initial line of antibiotic treatment, you can consider an aspiration at that time. And if that aspiration shows any significant concerns, I think referral to infectious disease or orthopedic specialist would be necessary for tailored antibiotics at that point. Again, thanks for listening. I hope you enjoyed the episode. I think this is a common thing that we see quite often. I think if you're listening to this and you're not a provider, if you have an acute onset of elbow swelling, trying to treat this conservatively with compression to the area, something as simple as an ACE bandage would be quite helpful. If it is refractory to this treatment past 7 to 10 days, possibly 2 weeks, I think it's worth it to come in to see a provider for evaluation regarding this. And if at any point you have any systemic symptoms, fevers, chills, sweats, increased pain with range of motion, overlying warmth, redness, I think definitely come in for possible antibiotic treatment. Again, please follow us on social media, both on Instagram and Facebook. And hopefully we'll have a YouTube channel starting soon where we can share some x-rays as well, so you can have a better idea from a visual standpoint of some of the fractures we often see. Thank you.